Alrighty, good morning, everyone. My name is Quang, and I am a fourth year Pharm.D student on my pediatrics rotation with Dr. Sheffer McKee. And today I'll be talking more about Tourette syndrome. So, the learning objectives for today basically be able to describe the risk factors for Tourette syndrome. I'll be referring it as TS for short. Elucidate the pathophysiology of TS, list common signs and symptoms of TS, be able to perform a differential diagnosis for TS, and last but not least, given the patient scenario, design a treatment regimen for TS. And so, going to the epidemiology of TS, it's kind of unclear how many children actually have Tourette syndrome. Studies kind of estimate that one out of every 162 children have Tourette syndrome. It's about 0.6%. Half of children with TS may actually be undiagnosed, and about 44% of children diagnosed with TS in 2016 to 2017 have moderate or severe symptoms of Tourette syndrome. And boys are actually found to be 3 times more likely than girls to have this syndrome. But there's not really any racial, ethnic, or socioeconomic differences with this condition. Now, looking into like the age differences, 12 to 17-year-olds are actually twice as likely to have a diagnosis compared to the younger kids who are about 6 to 11-year-olds. And so looking at this graph right here, it kind of just basically shows you the percentage of children with or without Tourette syndrome and kind of any other comorbid conditions, any mental behavioral developmental disorder, like ADHD, behavioral problems, or anxiety. And so you can kind of see that, in the children age 6 to 17, many of these other disorders that we can see on this graph, in general, they have Tourette syndrome compared to not having Tourette syndrome. Now, switching gears into the cause and risk factors of Tourette syndrome, is actually not really too well understood. What we do know, though, is in fact that it is inherited as a dominant gene, meaning there's a 50% probability of parents passing the gene on to their offspring. Now, kind of like we talked about how boys are 3 times more likely than girls to have this syndrome. Going in the same vein, boys are 3 to 4 times more likely to display symptoms of Tourette syndrome. TS can be triggered by abnormal metabolism of dopamine in the brain, and there are some risk factors that are unclear that I just did want to bring up and mention. And so this would be kind of prenatal tobacco exposure, any complications during pregnancy, low birth weight, and infection. Now, going into the pathophysiology of Tourette syndrome, the precise anatomic localization for the expression of tics, which I will be talking about in a couple slides later, is kind of uncertain, actually. So we think it's likely results from a disturbance in the mesolimbic circuit. And so this kind of leads to a disinhibition of the motor limbic system. There's kind of like a failure of the cortical inhibition of inappropriate motor programs generated in the basal ganglia. We also found deficits in cerebral maturation, especially for the striatal interneuron migration. And it's also been hypothesized that there's also just kind of like autoimmune reaction after streptococcal infection as well. And so, like I mentioned in the previous slide about tics, basically the main symptoms of Tourette syndrome are tics. And so, what are tics? Tics are basically repeated sudden twitches, movements, or sounds. And so they could be blinking repeatedly or making like grunting sounds unwillingly. It's kind of, you can kind of think of it similar to hiccups, basically. So there's 2 types of tics, and it can be categorized into motor and vocal. And so a motor would be kind of those ones like blinking, shrugging their shoulders, or maybe like a kid jerking their arm. Vocal will be more of humming, clearing the throat, or yelling a word or phrase repeatedly. Um, Tics can also be categorized or broken down into severity as well. And so simple versus complex. And so simple just kind of involve just a few parts of body. So sniffing or squinting their eyes. Excuse me. Complex can involve several different parts of the body and can have a pattern. So, for example, they can be bobbing their head while jerking their arm and then like jumping up as well. So, like multiple different things going on at the same time compared to just a simple severity. So signs and symptoms. So it does kind of begin around 5 to 10 years of age. That's when clinicians, parents, and family members should be kind of keeping a lookout in the back of the head. Initial symptoms are actually those motor tics, and it's mainly in the head and neck area. And tics can be exacerbated during stressful or exciting times. And on the other hand, tics are actually improved. They're ameliorated when the person is kind of focused on a specific task or they're calm. And so, in most cases, fortunately, tics decrease in frequency during adolescence, and they actually disappear entirely into adulthood. Um, but however, conversely, there's also been some cases where tics can worsen into adulthood as well. So it's not like every child experienced this, and then like they just magically disappear. No, there's been cases on both sides of the spectrum. Now, going on to the diagnosis, there's actually no single test for the diagnosis of Tourette syndrome. It's primarily actually a symptomatic diagnosis. And so, kind of the criteria to diagnose Tourette syndrome is a presence of at least two motor tics and at least one vocal tic. Now, they don't have to necessarily be concurrent, but it should be for at least 12 months. The onset should be less than 18 years of age. And of course, when considering differential diagnosis, it's not caused by any substance abuse or any drugs or any other medical conditions as to speak. And so going on to like the differential diagnosis and how we can kind of differentiate Tourette syndrome from other conditions. Other conditions may be, um, you know, OCD, ADHD. Compulsions may be mistakenly diagnosed in patients with complex tics. Stereotypies may occur in autistic spectrum disorders. Of course, there may be some unique mannerisms as well, that may seem like tics, but they shouldn't be diagnosed as Tourette syndrome. Um, Dystonia, myoclonus, and transient motor and phonic tics lasting for less than a year. And so these are kind of more transient, and it really shouldn't be diagnosed as Tourette syndrome. And so going on to kind of like the meat of this presentation, the pharmacologic treatment. Now, I did want to make a disclaimer, of course, non-pharm therapy, like cognitive behavioral therapy, for the most part, is generally always first line for these kids with Tourette syndrome. The pharmacological treatment, the first line therapy would be those alpha 2 agonists, so like clonidine or guanfacine. My presentation, I'll be specifically focusing on Abilify or aripiprazole as the generic name, since I did want to shed some light on this medication as a atypical antipsychotic that's been kind of gaining some traction for the treatment of Tourette syndrome and tics. Now, a randomized double-blind placebo-controlled trial concluded that oral Abilify is a safe and effective treatment for tics in children with Tourette syndrome. Now, I do have like the dosing right here, and so as you can see, for children for 6 to 18-year-olds, it's kind of like a weight base, or the dosing is divided based on the weight. And so if the patient is less than 50 kilograms, you would want to start at 2 milligrams daily for 2 days, increase target of 5 milligrams per 10. Now, if it's not really to control, the dose can be titrated up to 10 milligrams per day. Now, if the patient weighs at least 50 milligrams or 50 kilograms or more, excuse me, same thing, kind of type of deal with you start with 2 milligrams daily for 2 days, increase to 5 for 5 days, and then the target dose in this case would be 10 milligrams on day 8 of therapy. And they can also increase it up to 20 milligrams per day as well. And so the study actually had 3 treatment arms. And so they had a placebo arm, a low dose Abilify, and a high dose. So low dose was kind of like based on the weight that we talked about. And so 5 milligrams, less than 50 kilogram. 10 milligrams is 10 milligrams per day if it's at least 50 kilograms. High dose Abilify is starting at 10 milligrams if less than 50 kilograms, and then 20 milligrams per day if the patient is at least 50 kilograms. Now, after about 8 weeks after the conclusion of the trial, the study found that 69 of patients in the low dose arm and 74% of patients in the high dose group, they basically demonstrated a clinical global impression TS improvement score of 1, very much improved, or a 2, much improved, compared to 38% in the placebo group. And so as you can see, it's a very, very effective treatment for tics in children with Tourette syndrome. And, safety-wise, the study didn't actually really find any no deaths occurred and no serious adverse effects occurred either. So none of those extrapyramidal symptoms that would generally be kind of associated with the antipsychotics, even though, to a lesser extent in the atypicals like Abilify. Now, the most common adverse effects, though, that I did want to mention were sedation. And so it was about 18.2% versus in low dose, and then the high dose, and then placebo. And then, of course, somnolence as well. Of course, higher in the high dose group, and then consecutively to the low dose and then placebo. And of course, fatigue as well. Now, going on to like some of the most common dosage forms available for this medication would be there's 3 main ones. So oral solution in a concentration of 1 milligram per milliliter. There's an oral disintegrating tablet, which is nice, 10 milligrams and 50 milligrams. And of course, the main one is oral tablet. So it comes in 2, 5, 10, 15, 20, and 30 milligrams. Now, lastly, I did want to touch briefly upon the prognosis of Tourette syndrome. And so typically, it is characterized by kind of like a waxing and waning course. So there's kind of like a peak severity in the teenage years. And then after about puberty, that's when it starts to stabilize and improve. And so patients usually have improvement, or they kind of see the resolution of tics by their late teens or early 20s, which is nice. Alrighty, so that pretty much wraps up the end of my presentation. Thank you very much for taking the time to listening on this in-service. I do appreciate it. If there's any questions, comments, concerns at all, please feel free to contact me. My email is listed right there. Thank you very much, and I hope you all have a wonderful rest of your day. Thank you. Bye-bye.